My name is John Zacklin. I am a family nurse practitioner student enrolled in the program at Northwest Nazarene University, and I'm here today to present a PowerPoint presentation on platelet disorders. My goals for this presentation are to kind of talk about what platelets are, how they work, why platelet disorders specifically matter, what kind of platelet disorders there are, most common types, what are you most likely to encounter in your practice. I'll kind of talk about how we diagnose platelet disorders, what we're looking for specifically as far as the testing goes, what signs and symptoms we should be looking out for in the patient population, what other differential diagnoses are potentially needed in situations where the signs and symptoms are similar to that of platelet disorders. And then finally, we'll kind of look at the treatment for platelet disorders and then go one by one through the most common types of platelet disorders. So you may ask, why do I need to know about platelet disorders? Although platelet disorders are individually quite rare, platelet dysfunction in general, so that's including both inherited or acquired conditions, are not as uncommon as you might think. For example, thrombocytopenia, which is low platelet count, is observed in the general population at a prevalence of around 1 to 2% at some point in their life. Although not every case is directly linked to a dysfunction of the platelet itself, many people will experience some kind of platelet disorder in their lifetime. You might say, what are some factors that might contribute to why platelet disorders are rare? Could potentially be to a lack of awareness. Many healthcare professionals aren't always considering them while diagnosing patients with unexplained bleeding, potentially leading to an underreporting of how prevalent the platelet disorder actually is. Some of it has to do with challenges with diagnostics. Oftentimes the signs and symptoms, the bleeding, the bruising can overlap with other conditions that may kind of muddy the water when trying to figure out the diagnosis of platelet disorder. They can come with severe complications, bleeding, increased risk for blood clots, stroke, and pretty severe complications with pregnancy are also all relatively common with platelet disorders. And then kind of the final reason why I think platelet disorders are important, I have personal experience with a family member who had platelet disorder most of his life that then transitioned into a myeloproliferative neoplasm that ended up taking his life. So kind of have some personal experience with platelet disorders and why they're important. So what are platelets exactly? Platelets are also known as thrombocytes. They're a small, kind of disc-shaped cell that floats around in the blood, and they play a critical role in the formation of blood clots. As they circulate around the bloodstream, they help to form hemostatic plugs combined with other proteins that kind of help stop bleeding. They are much smaller than red or white blood cells, so they're kind of easier to differentiate when looking at the components of blood, and they help to prevent excessive blood loss when a blood vessel gets injured. So kind of a little bit on how they work. If a blood vessel gets injured and the underlying tissue is exposed, it can trigger a response um, where the platelet gets activated. They kind of change shape, become more spiky, sticky, help them adhere to one another, and then through um, other proteins in the blood like collagen and fibrinogen, the platelets kind of create a plug that ends up sealing the wound, and that's usually what you see on the outside in the development of coagulated blood and eventually a scab that heals. Platelets themselves live in normal circumstances between 7 to 10 days, but this can fluctuate in response to pregnancy, pathophysiological stress, and in women, it can change in response to um, menstruation. Platelets are produced in the bone marrow um, through the response of a hormone um, called thrombopoietin that kind of triggers that bone marrow to produce um, megakaryocytes, which then shed platelets. So moving on, kind of talking about just the types of different platelet disorders, um, and kind of an overview of each one that we're going to talk about. So thrombocythemia and thrombocytosis are both elevated platelet count. One, the essential thrombocythemia is just caused by it's a myeloproliferative disorder that is essentially just the overproduction of platelets that's linked to an abnormality in the stem cells of the bone marrow. Whereas reactive thrombocytosis is essentially just the overproduction of platelets in response to some other stimuli. It could be infection or inflammation. Um, and we're also going to talk about thrombocytopenia, which is low platelet count. This can be caused by a reduction in platelet production or certain medications potentially. Uh, kind of the third and kind of final category for the types of platelet disorders would be the dysfunction of the platelets themselves. So this could be an issue with the shape of the platelet, either too big or too small, an issue with how the platelet reacts to the clotting factors that are released when there's damage to a cell. So maybe the platelet doesn't change shape like it should, or doesn't bind to collagen like it should, or doesn't grip with the fibrinogen like it should. And in that case, the actual platelet itself, there's a dysfunction with the actual function of the platelet, not necessarily the number of the platelets themselves. How are platelet disorders diagnosed? Um, Primarily, platelet disorders are diagnosed by a combination of physical exam and laboratory testing. We'll talk about the signs and symptoms that a patient may exhibit here in a second. But the most common lab tests that are used to diagnose platelet disorders would be a complete blood count. This evaluates the actual number of platelets, not necessarily the shape or size, but the platelet count will tell you if there's too many or too little platelets in the peripheral circulation. Coagulation studies are often done. This actually looks at the clotting ability of the blood. Not necessarily tells you specifically about the platelet, but will help tell about other clotting factors and things that interact with the platelet and see how well your body is able to clot. A peripheral blood smear may be done to examine the actual morphology, the shape, the size of the platelet. This kind of helps differentiate what specific platelet disorder is present. Bone marrow aspiration might be done. This is done to investigate production issues to see if the bone marrow itself is healthy or if there's an issue with that. This is usually pulled if they see an abnormality on that peripheral blood smear that we discussed a moment ago. Because many platelet disorders lead to a dysfunction in the ability to clot, the primary symptoms that are usually seen early on and that help lead to diagnosis is easy bruising. Um, Individuals with platelet disorder might notice bruising after just like even like a minor bump or an injury, and then bruises may appear bigger than you would expect based off the trauma, and seem like they may take forever to heal in regard to a normal bruise that you've experienced in the past. Women may experience excessive bleeding during menstruation or during childbirth. Um, they may notice like a heavier than normal period, um, and due to that may feel lightheaded or dizzy due to that blood loss. Um, Petechiae is a pretty common sign of a platelet dysfunction as well. It is small or red little purple spots that appear on the skin, and these are due to little capillaries that are underneath your skin breaking. And so if your platelet becomes too low, platelet level becomes too low, pretty much any stress to your body, even rubbing up against something too hard, can break those kind of micro um, blood vessels, those little capillaries, and they can leak out blood. So these spots are usually not raised. They're usually not, they don't appear like hives. They don't itch. They don't burn. They just kind of show up, and most people see this and come in either to their primary doctor or the emergency room for complaints of a rash. Patients might notice that they get frequent nosebleeds or their gums bleed while they're brushing their teeth. They may notice some intermittent blood in their urine or intermittent blood in their stool. In more severe cases, you could end up with pretty life-threatening internal bleeding, like a gastrointestinal hemorrhage where you're vomiting blood or having significant um, blood in your stool. There's also possibilities of bleeding in your brain or in your spinal cord, but those are usually the more severe cases, and these other symptoms are usually seen prior to those life-threatening signs and symptoms. As with any condition, there's always other disorders or um, diseases to consider when diagnosing someone with a platelet disorder. Um, so here's just a couple common diagnoses to consider when you evaluate a platelet disorder. Sickle cell disease, for instance, can cause um, vaso-occlusive episodes, which is kind of its most common and kind of hallmark symptom. But as those clotting factors get used up in the occlusive episodes, you can also end up with excessive bleeding. So in this case, when you test someone for sickle cell disease, the platelet test would be normal, but you would obviously see an abnormality in the red blood cell tests on the peripheral blood smear. Cirrhosis of the liver can lead to bleeding and clotting issues as the production of other factors that are important in blood clotting get impaired with liver impairment. And so this would be differentiated between a platelet disorder by looking at if there were signs and symptoms of liver disease, such as abnormal liver function tests or potentially jaundice in the patient, looking at the bilirubin level in the blood test, and then kind of finally the other differential diagnosis could potentially be disseminated intravascular coagulation, which is a very severe and life-threatening disorder that can cause widespread clotting and excessive bleeding. And similar to in the vaso-occlusive episodes, if you end up with using up a lot of your clotting factors, you can end up with excessive bleeding. So in these cases, these patients might end up with blood clots and severe hemorrhage at the same time, which is why it is so dangerous and potentially life-threatening. The differentiating test between disseminated intravascular coagulation and platelet disorders would be looking at coagulation studies to kind of see the specifics of whether or not this is a platelet issue or a clotting factor issue. The treatment for platelet disorders varies greatly depending on what type of platelet disorder is identified and what the specific cause for that platelet dysfunction may be. So depending on the case, the treatment could be antifibrinolytic agent might be used in cases where there's severe bleeding, like gastrointestinal hemorrhage or bleeding in the brain. A medication like tranexamic acid, also known as TXA, may be given to help with the blood clotting factors. Immunosuppressive therapy might need to be used depending on the cause of the platelet dysfunction. If there's an immune response that's damaging the production of platelets or damaging healthy platelets, a medication such as a steroid maybe need to be used in order to kind of suppress your immune response and protect the platelets. In cases where the platelet count is very low and bleeding is severe, you may need a platelet transfusion to help replace the limited number of platelets that you have. This may be also used in cases where there's potential for severe bleeding, such as prior to a surgery or an invasive procedure, or prior to childbirth, where we know that the risk for hemorrhaging postpartum is high. Sometimes the treatment is as simple as stopping a medication that you might be taking. Certain medications, sometimes NSAIDs or aspirin, in certain people can inhibit the production of platelets, and so stopping these medications may be the treatment that's needed. It's your job as the primary care provider to also come up with an alternative medication for them to take that still meets the needs of their body without impairing their production of platelets. Thrombocythemia is a primary genetic disorder. It's usually referred to as essential thrombocythemia. Essentially, this is a stem cell disorder where excessive platelets are produced. This is not a issue with platelet survival time, where they live for super long. This is where the bone marrow produces too many platelets. This disorder isn't directly genetically linked. There's no familial cases really that they've seen, but genetic predispositions have been observed, and there does seem to be a link between this and myeloproliferative neoplasms, which is the way that my dad ended up with cancer. Most cases of this are asymptomatic. Sometimes patients don't even know they have this until they go have blood work taken, but it does increase your risk for thrombosis and increased risk of pregnancy loss has been observed with women with this condition. Reactive thrombocytosis is similar to essential thrombocytopenia in the fact that the platelet count is elevated, but the difference is that thrombocytosis, reactive thrombocytosis, is due to an external factor that is affecting the production of platelets. So these could be anemia and blood loss, including like iron deficiency or hemolysis. Your body, as it's cranking out more red blood cells in response to the blood loss or the anemia, maybe making platelets as well, which leads to an imbalance of platelets to red blood cells, and you end up with increased platelet count in the blood. Certain infections like viral or bacterial and sometimes even fungal infections can cause a inflammatory response that triggers your body to make more platelets, kind of stimulates your bone marrow, and so that may be an issue with thrombocytosis, reactive thrombocytosis. There's also inflammation that could be caused that wasn't infectious, so like either malignancy or certain reactions to medications, or sometimes even physical trauma to the body can trigger a release of platelets that end up increasing your platelet count. Kind of the last noted reason for potential reactive thrombocytosis is after you have your spleen removed. The spleen is a place that can hold excess platelets. So if your body produces too many or immature platelets, they may end up being stored in your spleen and pulled out of peripheral circulation until they're needed. But if you don't have a spleen, then you have no way of kind of buffering the platelets that are in your peripheral circulation. Thrombocytopenia is characterized by a low platelet count and can arise from a variety of different conditions and can lead to a wide range of different outcomes, all the way from patients who are asymptomatic to severe cases of bleeding, hemorrhage, and death. Thrombocytopenia is the opposite of thrombocytosis or central thrombocytopenia, where the platelet count is high. In thrombocytopenia, the platelet count is low. The severity is graded anything less than 150,000 platelets per microliter is considered mild thrombocytopenia, and then it takes steps down from there to anything less than 50,000 platelets per microliter is considered severe thrombocytopenia. The threshold can vary on the person as well as what the underlying condition is for it to be considered severe. The bleeding risk varies kind of in direct correlation to the platelet level. So the lower the platelet level, the increased risk for that bleeding. Clotting can actually become a concern depending on the condition that's causing the thrombocytopenia. And in these cases, the patient is very difficult to manage because there's a increased risk for not only bleeding, hemorrhage, and death, but clotting that can cause severe complications such as a heart attack or a stroke. Some of the causes for thrombocytopenia primarily would be decreased production of platelets. This could be caused primarily by bone marrow disorders, since the bone marrow is the main system that produces the production of platelets. So syndromes like aplastic anemia, where the bone marrow doesn't produce enough blood cells, is often thought of as like a red blood cell problem with aplastic anemia, but platelets are also not produced appropriately in that condition. Leukemia, so blood cancers often crowd out the normal cells, crowd out and kill the normal cells of the bone marrow, and that inhibits platelet production. This is what ended up happening to my dad, and he ultimately passed away from it. But certain therapies, such as chemotherapy or radiation, can also damage the bone marrow, which is obviously what produces the platelets, and so this could be a more gradual reduction in the production of the platelets as there's more and more treatments applied to the patient. Vitamin B12 or folate deficiencies can also cause decreased platelet production. These vitamins are very important for cell production. in the bone marrow uses up these vitamins in order to make platelets, and so without them, there's significant risk for thrombocytopenia. The second primary cause for thrombocytopenia would be an increase in the destruction of platelets. Usually, this is mediated by the immune system. So the immune system, mistakenly identifies platelets as a target, destroying them and leading to thrombocytopenia, bleeding, and potentially hemorrhage. Some of the conditions that cause this would be immune thrombocytopenia purpura. That's an autoimmune disorder where your immune system again identifies your platelets as foreign and attacks and destroys them. There's drug-induced thrombocytopenia, where there's certain medications, NSAIDs or aspirin in this case, potentially heparin, which usually leads to what's called heparin-induced thrombocytopenia. But essentially, again, the heparin's effect on the system triggers an immune reaction that destroys platelets. We talked a little bit about disseminated intravascular coagulation earlier, but it is a condition where essentially like the widespread clotting in your small blood vessels consumes all of your intravascular platelets. So it's not so much that they get destroyed or attacked by your immune system, but in DIC, all of your available platelets get used up, and then while you're clotting, you're also at a severe risk once you run out for severe bleeding. Hemolytic uremic syndrome is often associated with bacterial infections. One primary example would be E. coli, and essentially this leads to, similar to DIC, but it leads to clotting, issues with your kidney function, potentially leading to kidney failure, as well as destruction of healthy functioning platelets. The third and kind of final primary cause for thrombocytopenia would be considered, the trapping of platelets. As we discussed a little bit earlier, the spleen can remove platelets from peripheral circulation to kind of help buffer the system, releasing them when they're needed, or pulling them out of the system when there are too many. And so if you end up with an enlarged spleen or splenomegaly, essentially that spleen can hold on and trap those platelets as they flow through, which reduces the number in peripheral circulation. This most commonly occurs in issues where you have something that is either damaging or irritating the spleen. So like in cirrhosis of the liver, you end up with portal hypertension, which kind of backs up the flow into the spleen and causes the enlargement and the trapping of those platelets. In hypersplenism, it's essentially just a condition where there's an overactivity of the spleen, which leads to the excessive removal of those platelets from the peripheral circulation. Again, removing your body's ability to clot blood. Viral infections can irritate your spleen, again, which causes the removal of the platelets from the peripheral circulation, as well as alcohol use can damage your liver in a way that inhibits the production of other clotting factors, meaning you may use up more of your platelets than you usually would, as well as alcohol kind of impairs the production of platelets from your bone marrow. Although there are a countless number of hereditary disorders that are associated with platelet disorders, The one that I'm going to talk about today is von Willebrand disease. It's the most commonly inherited bleeding disorder, and it affects the body's ability to clot properly. This isn't actually a specific dysfunction with the platelet itself, but rather a dysfunction of the von Willebrand factor, which is the critical protein that allows platelets to adhere together, making a blood clot. So there's three types of von Willebrand's disease, type 1, 2, and 3. 1 is the most mild. It accounts for about 80% of cases, and this is just a partial deficiency in the factor. So symptoms are often relatively mild, and this one is autosomal dominant, so only one parent is needed to have the gene in order to pass it on to their offspring. Type 2 is a more moderate form. This cause is a more severe issue with the Willebrand factor, which creates poor platelet adhesion. Sometimes these symptoms are more severe, usually spontaneous bleeding, heavy menstrual bleeding, but type 3 is the most severe. Thankfully, it's the least common, and it's autosomal recessive, meaning that both parents have to have the gene in order to pass it on. But this can cause severe bleeding, like into the muscles, the soft tissue, or the joints, and can cause serious issues with anemia or hemorrhage. Just wanted to say thank you for listening to my presentation on platelet disorders. This concludes the information I wanted to cover. I hope after listening you have a better understanding of the most common types of platelet disorders, kind of how we identify them and how we treat them, as well as a understanding of why it's important to be educated on platelet disorders and platelet dysfunction. Thank you.